For now we say, when I get older, I will be stronger. They'll call me freedom, just like a waving flag. And then it goes back, and then it goes back.
Good afternoon and welcome to today's webinar, Navigating Long COVID. Thank you for joining us today. Next slide, please. Before we get started, we want to take a few moments to go over some housekeeping pieces that will keep this running smoothly for everyone. How to use Zoom interpretation and captioning, our virtual meeting practices, and then OHA staff introductions, as well as chat and Q&A. Next slide, please. Okay, first, if you need to listen to language interpretation on your computer, these are the steps. In your meeting and webinar controls, click Interpretation. There is a small globe at the bottom. Click the language that you would like to hear, for example, Spanish. To hear the interpreted language only, please click Mute Original Audio. Angélica?
¿Cómo escuchar la interpretación en español en su computadora? En los controles de la reunión o el seminario web, haga clic en Interpretación. Hay un circulito que parece como un globo y ahí marque Español. Para escuchar solo el idioma interpretado, haga clic en Silenciar el audio original. Len?
Next slide, please. If you are on your phone, these are the instructions. In your meeting controls, tap the ellipses. It looks like 3 small dots. Then tap Language Interpretation. Select the language you want to hear, for example, Spanish. And then optional, to listen only to the interpreted language, tap the toggle to mute original audio, and then click Done. Angélica?
En los controles de reunión es cómo escuchar la interpretación en su teléfono. En los controles de reunión, toque los puntos suspensivos. Estos parecen como unos puntitos. Y ahí toque Interpretación de idiomas. Toque el idioma que desea escuchar, que es el español. Para escuchar solo el idioma interpretado, toque el botón Silenciar audio original. Gracias. Len?
Next slide, please. I'm going to go over our virtual meeting practices. You may notice OHA staff doing the following: giving visual descriptions of our appearance on screen, stating our names each time we speak, pausing for interpreters and closed captioning, and explaining acronyms the first time they are used. The purpose of these practices are to be inclusive of participants with disabilities and those joining by phone. Next slide, please. My name is Lynn Russell. I use she, her pronouns. I'm an Asian person in my 40s. My long dark hair is pulled back. I'm wearing a black top with white dots and a rust-colored cardigan. I have a headset on and I'm sitting in my home office / living room. I'm an equity analyst with the Outreach and Engagement team, and today I'll be your facilitator as well as the moderator for the Q&A portions. We know that long COVID is on many people's minds, including my own. Perhaps you are here because you're experiencing long COVID, you know and care for someone who is, or you want to learn more. Today's webinar will include presentations from Oregon Health and Science University, the Oregon Bureau of Labor and Industries, and Disability Rights Oregon. We will cover as much as we can over the next 2 hours, leaving time for your questions after each presenter. We know we won't get to everything, nor be able to address everyone's questions and concerns, but we will do our best. As a reminder, this session is being recorded, and we will make the recording slides and frequently asked questions document available after. Because of the number of people on the call today, the chat is limited to messaging OHA staff so that we can best track your questions and support needs. We have an incredible team working behind the scenes to make this run as smoothly as possible, as well as many OHA staff who supported the work to get this webinar set up. Please extend some grace if we run into glitches. So during the session, please direct message the following staff. For general tech support, Ian Goss. For support or questions in Spanish, Angelica Rupe. And for questions for presenters, myself, Lynn Russell, or Christine Getman. You can also raise your hand to ask a question during the Q&A portion, and we will call on you. We will get to as many questions as we can. Please remember that presenters cannot answer personal questions. We are grateful for our presenters' time and expertise, as well as your own. Please engage respectfully and know that we are here to serve you. We do want to hear your feedback, and we'll send out an after-session survey along with our materials. I'm going to pass the mic to my colleague, Christine.
Thank you, Lynn. Hi, everyone. My name is Christine Getman. I use she, her pronouns. I have long, dark hair that's styled down, and I'm wearing a gray sweater with red lipstick. My background is a rust-colored wall with some framed artwork behind me. I'm the accessibility team manager with the Oregon Health Authority, and today I will also help moderate the Q&A, reading your questions aloud. Next slide, please. Our agenda today is structured, so we will have several opportunities to learn and ask questions together. First, Dr. Aluko Hope from Oregon Health and Science University will share about symptoms, treatment, and advocacy tips. Then we will have a Q&A session with Dr. Hope. We will take a short break after about an hour together, and then Dylan Morgan from Oregon Bureau of Labor and Industries will share about workplace rights, and Emily Cooper from Disability Rights Oregon will share about disability identity and accommodations. And then we will wrap up our time together with another Q&A session with them. Next slide, thanks.
This is Lynn. It is my pleasure to introduce our first speaker, Dr. Aluko Hope. Dr. Hope is Associate Professor of Pulmonary and Critical Care and the Medical Director of the Long COVID Program at OHSU. He is a physician scientist whose research focus is on improving the recovery of adults after acute illness. Dr. Hope, thank you so much for being here with us. The floor is yours.
Thank you so much, Lynn, for that introduction. I do use he, him pronouns. I'm a Black man sitting in my office, home office, with bookshelves around me. Hopefully the Virginia Wolf is safe behind me. And I have a beard that's gray. And I'm happy to talk today about navigating long COVID. Next slide. You can go to the next slide as well. I don't have commercial financial interest. I have some funding from the NIH, and I will say as part of the disclosures that some of the things that I will talk about a lot of what I will be talking about is based on the lived experience of working with patients over the last 3 years. I think that's important to acknowledge because the typical ways in which we come to know things in medicine might not be quite ready for long COVID, and yet I think there's a lot that we do know from the lived experience, and I wanted to share that with you today. Next slide. So we'll be discussing the symptoms and the signs of long COVID, and then we'll be talking about some of the approaches for managing the symptoms that we use here at OHSU that we think are sort of at the edge of the evidence for how to manage patients. You'll see as part of the objectives, I don't necessarily name as an objective to give you advocacy tips, but my hope is that by talking about these two things, that you'll walk away with some approaches to how to engage the health system with long COVID. Next slide. So we'll go through a few cases, talk a little bit about the pathophysiology and epidemiology, and then do a little bit of the evaluation and treatment, and then return to the cases. And at the end, you'll see that there are resources available in the slides that will be forwarded to those of you who have access to the slides. Next slide. Are people able to hear my voice okay, or should I be speaking louder? Because I'm seeing some.
This is Lynn. Dr. Hope, it sounds like your voice is a little bit quiet.
Very quiet.
Let's see how I change that.
Please speak louder.
I can hear you just fine.
So let's hope that I can, is that better just with me speaking louder to the audience at this point?
Yes.
Because my volume is as loud as I think I can make it. And so it might just be that I'm not enunciating as loud as I need to be. So we'll start with describing a few cases. VW is a 55-year-old woman. She does have some medical history of high blood pressure, pre-diabetes, obesity, and depression. And she got COVID in December of 2021. And her acute COVID symptoms were, as you might imagine, sore throat, cough, fatigue, difficulty with smell, some lightheadedness and sleepiness, and some muscle pain. And she's presenting to the long COVID specialty clinic 4 months after her acute COVID illness, describing fatigue that she describes as wearing a lead weight on her body. She's suffering profound exhaustion during the days. Her heart is racing on occasion. She has difficulty breathing whenever she tries to do any aerobic activity. And she has difficulty finding words and staying focused and multitasking. And she was somebody who, as a nurse, was really quite the multitasker before her illness. And she's having difficulty with her sleep, getting to sleep, and also staying asleep at night. And this has really affected her well-being in a lot of different domains. Importantly, she's not been able to work a full 40-hour work week. And she feels that when she goes to her doctor, she's been particularly dismissed by the medical community. She says at one point, her cardiologist, in evaluating the heart racing, said that this might be, quote unquote, all in her head. And she spent a significant amount of her savings trying to understand what's happening to her body. And she's really exhausted her unpaid time off from work. Next slide. WW is a 43-year-old genderqueer person with a history of autism. Their acute COVID symptoms really were very similar to the previous patient with cough and fatigue and sore throat. And they're presenting 18 months after their acute COVID illness. And they used to work as an information technology worker, and now they're really suffering such profound social and cognitive exhaustion that they really have not been able to work adequately in the position. They're also suffering with heart racing at night, which is leading to difficulty falling asleep. And if you probe, at this point, although it was much worse, this is 18 months after the beginning of the illness. And so in the beginning, the exercise limitation was an important component of what was going on. That piece of the story has improved significantly, such that that's not part of why they're presenting to the COVID clinic today. And yet, if you probe, that is something that's there still and not back to the baseline that they had before the illness. Their ability to plan and organize things and focus is also significantly impaired. And in fact, their duration of activity that they can spend doing any kind of cognitive task is very limited. Within a few minutes of computer work or social interaction, they're so limited that they almost get a headache and feel froggy that they have to go lie down. And so as you can imagine, this is affecting their ability to work. They've needed more help to navigate the medical system because of the social challenges of that. And this has led to social isolation and depression. The next slide. The third patient, JK, has a history of Ehlers-Danlos syndrome, which is a medical illness that affects the connective tissues, where they might be more flexible in some of the joints, and that can come with certain kinds of pain over time. JK also has obesity and got COVID in May of 2022. And her acute COVID symptoms were very similar to the previous two patients, but she's presenting now 12 months after her COVID illness. And really she's coming to the COVID clinic thinking that she wants a third opinion. She was seen by a Dr. P virtually for long COVID, and she's been seen at the Mayo Clinic for long COVID. And she already has a diagnosis of long COVID, mast cell activation syndrome, dysautonomia, small fiber neuropathy. And despite all of these diagnoses, she's still struggling 20 hours a day, spending most of her day in bed. After every medical appointment, she's crashing and having to spend sometimes hours or days recovering from the having to get up and do the appointments, even when it's virtual. She's suffering with difficulty finding words, staying focused, and she's also having difficulty doing her instrumental activities of daily living. And so those are activities like shopping, going to the grocery store, answering the telephone. She's really, really getting quickly exhausted doing any of those things. And her husband really has had to take over a lot of that work for her in the family. She has a lot of social support, but despite that, she's applying for disability through the SSI. And she's really suffered financially as a result of all the medical appointments, the fact that she can't work, and the fact that they're spending a lot of her savings going to these medical appointments. The next slide. So what's happening in these cases? The manifestations of long COVID that we're seeing in a lot of these cases are quite similar. We're seeing patients with physical fatigue. We're seeing symptoms of what we call in the medical community post-exertional malaise, which is really a poorly named symptom complex that really is when your symptoms get worse when you quote unquote overdo. And the overdoing can be quite little, but the worst thing in your symptoms can be quite delayed either by minutes or hours or days after the overdoing. And so the overdoing could be either in the physical domain, in the cognitive domain, in the social domain, in the sensory domain as well. And so post-exertional malaise is what we tend to call that. And it tends to go along with a physical fatigue. You see a lot of cognitive impairment in patients with long COVID. Dysautonomia is another fancy term that really just refers to that autonomic nervous system, the part of the nervous system that's really supposed to be automatic, that manages our blood pressure, our heart rate, how we move in our bodies, and how our blood pressure and heart rate changes in response to body position, how we digest our food. These are all things that are managed very automatically at the lower part of our brain by the autonomic nervous system. And it's a very complex set of nerves that run throughout our bodies. And when the body has difficulty with balancing the sympathetic system, which is really involved in that fight, flight, fear response that we all have to be able to do when we are engaged with things that can cause us a lot of stress, and the relaxation component called the parasympathetic system, that balance can be really impaired and you can get dysautonomia, where the brain is not responding in the way that it typically responds to those kinds of changes that you need to do, like body position or heart rate or blood pressure. Cognitive impairment we mentioned as well, and sleep changes is very common. And whether or not the depression, anxiety, and post-traumatic stress symptoms are coming along with the syndrome, or whether they're coming as a result of having had some of these challenges, I do think it's important to acknowledge that, that these impairments are quite common within long COVID. And so you'll see on the left, the things that patients are describing sort of matching with what we see are very common manifestations for long COVID. Next slide. As we mentioned, there is no official definition that's been decided on for what is long COVID, but I think a consensus seems to be emerging at the level of a lot of the agencies in the world, including the World Health Organization, that long COVID is going to be defined as a syndrome when patients have new or persistent symptoms for at least 3 months after the onset of COVID, when the history of COVID has been probable or confirmed. That probable is italicized, partly to highlight that often patients might not have had a confirmed SARS-CoV infection when they present with symptoms of long COVID. And that's just a fixture of the way the health systems work, and the fact that many patients who get long COVID might have had a mild enough illness that they may not have needed testing when they were getting their acute COVID illness. These symptoms last for at least 2 months, and they really can't be explained by another diagnosis. I think there's sometimes language about it has to be a quote unquote diagnosis of exclusion, which I bristle with, because I do think that if you listen closely to the histories of patients with long COVID, you can pick up when it's presenting even early on. And I think it doesn't necessarily you don't have to rule out everything in order to call it long COVID. And yet I do think that it's important to rule out some basic things that can cause a lot of similar symptoms that patients with long COVID present. Next slide. What are some of those symptoms? We mentioned a lot of them already. The fatigue and the shortness of breath and the post-exertional malaise, which is just the worsening of the symptoms with overexertion. Pain is a very common one, particularly pain in the nerves, which we call neuropathic pain. Palpitations, or your heart beating really fast or inappropriately fast, I think can be another common symptom. Gastrointestinal symptoms can be very common because the autonomic nervous system is very involved in that system. So you can have constipation, you can have diarrhea, you can have bloating, or easy satiety, meaning you're getting filled very easily after eating. Changes in smell and taste can also be something that we see. Headache can be a very common symptom as well. Joint and muscle pains, and any number of symptoms. Often the many number of symptoms that we won't list here come in the context when patients are really spending a lot of time overdoing it, doing symptoms that are really above their energy, what their energy system can bear. And then in that context, they really can have a lot of other symptoms that can be way beyond this list. The next slide, please. And so I think it's important, although this is something that is at the edge of the evidence, to highlight that we're seeing some phenotypes, right? Lots of people have post-COVID complications that are very simple and very common, even for compared to other viruses, whether it's a chronic cough, whether it's neuromuscular weakness because they've been lying in bed for so long after being ill, whether it's a new lung disease after having a lung infection like COVID, right? For those things, we're not really going to talk about that at all today, right? When we talk about long COVID, we're really talking about a syndrome of multiple systems impaired after having COVID, right? And so this is the patient with fatigue, the post-exertional malaise, the cognitive changes, the sleep changes, and the exercise intolerance. The next slide, please. And then I think we try to pick out the patient with autonomic impairment. That's the dysautonomia, partly because I do think that that set of symptoms really lend itself to a particular type of treatment that I think it's important to highlight. And so these kinds of symptoms would include things like dizziness, lightheadedness, your heart beating really fast, feeling faint, sometimes palpitations, you're feeling breathless when you're walking up and down stairs, or again, like the bloating and the diarrhea or the constipation that we talk about. And then the small fibers in the body, meaning the fibers that send pain or tickle sensations can also be impaired, and you can get sort of inappropriate sensations of burning and tingling in your feet or in your arms, and that can be a sign that the small fibers are inflamed as well. And those are all things that we see when somebody has dysautonomia, meaning an impaired autonomic system, which is that part of the brain that controls the sympathetic system and the parasympathetic system and the balance between it. And I think when we pick that up, I think it gives us a certain types of treatments that we can use in patients with that kind of symptoms. The other phenotype that we see often is that patients have all of the other symptoms of the fatigue, but then they might also have pain out of proportion to their exam, meaning they might have had a chronic pain syndrome beforehand, and now their back pain that they had before is now worse. They really can't get comfortable. They might have significant burning in their mouth. They might have burning in their jaw or in their pelvis, right? And so there's the sense that the brain has really lowered the threshold by which discomfort is going to be felt. And so these patients walk around in the universe with a lot of easy amount of discomfort, whether it be from pain or difficulty with balance. And that's something that we do see a fair bit as well. The next slide. And so although again, this is not something that's talked about in the literature, a lot of what's been described in the literature are the precipitating factors, looking mostly at the things that happen that are relevant to you developing long COVID based on when you get acute COVID, who is at risk for developing long COVID based on their the types of things that we can look at the acute COVID. And that what I would call that is precipitating factors, right? So patients who have a severe COVID infection, whether it be defined by the amount of symptoms, whether it be defined by the amount of virus in the body, and that's what we call the high level of viral mRNA, or whether the virus leads to a reactivation of other viruses that can lay dormant in the body, like EBV is a virus that is often lays dormant in the nerves and can be reactivated under stress. And so that's something that can certainly happen when somebody gets a viral infection like COVID. And then for some people who are just having the presence of certain markers of autoimmunity, meaning the body's immune system is as a result of having the infection, you're seeing signs that the immune system is not able to recognize the difference between self and foreign. And so you see autoantibodies. Those people seem to be at higher risk of developing long COVID from the literature. But in terms of factors that people come into the illness with, whether it be older age, physical frailty, obesity, diabetes, women do seem to be at more risk for developing long COVID than men. We would call those predisposing factors, meaning they're not things that you can necessarily change, and yet it's important to acknowledge that they might put you at higher risk of developing long COVID. And then I think they're the perpetuating factors, right? You get long COVID symptoms. What are the kinds of things that will make it difficult for you to get better when you get into that bucket of having symptoms? And I think financial issues, obviously, because this is an illness for which we don't have a lot of good treatments. And so if you're financially vulnerable, I think that's going to be a difficulty. If you don't have a healthcare provider or have access to good healthcare, that will be a challenge as well and can make getting better difficult. The social support, when you're struggling with fatigue and symptoms getting worse with overexertion, sometimes how you counteract that is by having people available to help you do things. And if you don't have that, that may mean that you may have to overdo it. I put overdoing in quotes in order to just live your life. And that may make it difficult for you to get better as well. And then certain personality traits, right? When you have an illness that's not well understood by the medical system, a lot of things have to be made explicit by both you and the clinicians. And when you have difficulty with doing that, I think sometimes that can make it really difficult to get better as well. And so let's go to the next slide. And the pathophysiology, I don't think we have to necessarily belabor the point here for this audience. I think it's important to acknowledge that a lot of what we're seeing in long COVID could happen through multiple different pathways. And these are not meant to be mutually exclusive. Some things may happen directly as a result of the virus and what the virus does when it's causing the infection, meaning the virus is COVID, whether it be because of continued inflammation in the body, persistent immune system activation, whether it be, there's still a debate about whether some people still have small amounts of virus replicating in small reservoirs of the body, whether it be in the gastrointestinal system, and maybe that's contributing to some of the symptoms. So those things are open questions that I think science is still debating and looking for different pathways. I suspect that it may end up being all of those things rather than just one of them. And then there are the independent mechanisms from the virus, meaning that you get an illness and just the organ damage from the acute infection can lead to symptoms that may last for a while. Whether it be from you unmask underlying chronic conditions as a result of the treatment for the virus or as a result of just being ill from the virus, that can also happen. And sometimes people who were in the hospital for a long time or in the intensive care unit develop a particular set of symptoms and complications just from being in that state that can look very similar to long COVID, and that might be contributing to what we might be calling long COVID. Patients who survive the ICU might have post-traumatic stress, might have cognitive impairment, might have difficulty with neuromuscular weakness, and those all things that might look very similar to long COVID. And then I think it's important to acknowledge that when you have chronic symptoms, your body adapts to those symptoms. So if you're very fatigued, your posture may change. When you're spending a lot of time putting yourself above your body's energy ceiling, your brain makes adaptations that may be good in the short term, but ultimately may create a whole set of other cascade of symptoms that we have to address as part of managing the long COVID symptoms. Next slide. And so what do we do in the evaluation and treatment? Next slide. I think it's important to acknowledge that although we don't often do this very well, when you have an illness that is not well understood, really in the medical system, we're really looking at your pre-COVID factors, looking at the disease severity, acute COVID factors that might be relevant, and then really trying to look at the psychosocial factors that might be helping you or causing you to have the symptoms progress or sustained in the way we manage each patient. Next slide. And so I think in terms of the evaluation, I think a lot of it is based on the history and in the exam. I think what can be confusing for patients when they present to a doctor with these challenges is that the doctors will spend a lot of time ruling out things by sending laboratory tests. I think it's important that we walk away understanding that at this time, that may change in the future, there is no one lab test to diagnose long COVID, right? And so everything that the doctor is sending in terms of lab tests, and when I say doctor, I mean any clinician, they're really ruling out other causes for the symptoms or other contributory factors that may be contributing to the set of symptoms that you present with. They're not going to be diagnosing long COVID with the laboratory tests. And I think that can be a very confusing thing because the lab tests overwhelmingly in patients with long COVID are going to be normal. And in fact, that's what we want. We want them to be normal. If you have a B12 deficiency or if you have a anemia that might be contributing to your shortness of breath or your fatigue, we want to be able to manage that in the way we manage B12 deficiency and anemia. That may be contributing to your fatigue, but it doesn't mean that you don't have long COVID. It's just something that we can manage alongside the long COVID. Next slide. And so a lot of what we do is we ask questions about the illness course. We ask questions about the impact on your life. We ask questions about what kinds of things make your symptoms worse. This is a relapsing remitting illness, right? And so certain triggers, certain stressors do make your illness and your symptoms worse. And asking about that, I think, is something that we spend a lot of time doing in the history of present illness. Next slide. And then we look at the social factors as well, because again, when you have a fatiguing illness, understanding that landscape is a really important component to what we can do to make you, even despite your symptoms, have you be able to be more capable and be more interactive in the world. Next slide. And the physical exam is not often very helpful, and yet it's important to do some basic things like check for signs that your heart rate and your blood pressure are not showing us signs that you have that dysautonomia that we talked about, that ability of that autonomic part of the brain to regulate the blood pressure and heart rate. Sometimes in the office, we can do orthostatics to see whether you have a suggestion that that might be present. But the rest of the exam often may not be helpful. Looking at hair loss, looking at skin changes, looking at the difficulty finding words are all things that we look for in the exam. Next slide. And when we look at the physical capacity, we're really looking at muscle strength, your ability to endure physical activity, because that's often impaired in patients with fatigue. Next slide. And again, the lab test, I'm not going to belabor here. I'm going to skip this slide and go to the next one. And I think it's important because there is a culture in America, and I think in the Western world, of a lot of overdoing. And I want to make sure that you guys walk away knowing that although we can look for a lot of things, when we're looking for a lot of things, we're really looking for contributory factors. We're not looking for things that will actually give you a diagnosis of long COVID. A lot of the diagnostic tests are not going to be abnormal. And that's what we would look for, right? So if you're getting a brain MRI, we're not going to pick up things on the brain MRI if you have cognitive impairment. And that can be frustrating to patients, but that's actually completely appropriate. Next slide. And so how do we manage long COVID symptoms? I'm going to give you the two examples for the fatigue and the dysautonomia, and then we'll try to, yes, and I think, and I'll try to go through this quickly in about 2 minutes and then take the questions so that we don't overspend the time. Next slide, please. We can go to the next slide because we've talked a little bit about the symptoms, and we can go to the next slide as well. Right, and I think it's important here that because of the level of evidence, we're really going to be individualizing a lot of what we do for each patient. We spend a lot of time teaching patients how to manage, how to energy conserve, because ultimately what we think is going on with long COVID is that the energy system is completely impaired, and that the energy ceiling, for using, to use a better word, has been lowered significantly by the virus. And because that energy ceiling has been lowered, when you spend more time above that lowered energy ceiling, that time leads to more physical fatigue, it leads to more crashes, it leads to post-exertional malaise. And so the very first part of the treatment is teaching patients how to conserve their energy, because this process, this illness, is not going to allow you to live in energy debt, right? If you spend too much of that energy above your energy ceiling, you're going to spend a lot of time with crashes and burns, and you're not going to be able to really get better. And so prioritizing your activities, planning very carefully for your activities, pacing appropriately, and then learning how to put yourself in the right posture to control your energy, right? So that you're not exhausting your energy. Because believe it or not, sitting up upright takes up a lot of energy. Standing upright for more than 5 minutes is a very aerobic activity. And so teaching people what parts of the posture is using a lot of their energy, I think, is a big component of what we have to do. Next slide. Right? And so I think that's the big component here, is titrating the physical activity to match patients' energy system. And so I'm not going to belabor the point about the different ways in which the body uses energy. One is very efficient and can be done for many, many hours. And one is inefficient and is just meant for very short bursts of energy use. But imagine if that threshold at which the body converts, switches over from very efficient energy use to inefficient energy use has been lowered by a lot. You might not think that's an important thing, but just that lowering of the threshold translates into a ceiling, an energy ceiling, that's functionally very, very low. And that's not something that patients get, and yet it's something that's happened as a result of the virus. And so I think we have to teach them about that and help them identify where their ceiling is. And it might be so much lower than it was before the illness that often people just don't understand how much lower it is and what that means in terms of how they have to really manage their physical activity, their cognitive activity, their social activity, and even the sensory stimulation that they're living in the world with. Next slide. And so a lot of what we spend time doing is rehabilitating that energy system. I think as a principle, what we want to do is by identifying what the energy ceiling is for each person, what we want to do is have them spend most of their time below that energy ceiling, but also spend more time or more and more time doing activities slowly below that ceiling. So it's about the duration of activity below the ceiling and avoiding intense activity that's above the energy ceiling. And for each person, depending on a lot of different factors, that energy ceiling is going to be at different levels, depending on fitness from before the virus, depending on the severity of the viral infection, depending on just maybe their genetic propensity. I don't think we understand much about how that happens, but it does seem to be a common thing that we see in almost all of the patients, is that their energy ceiling really has been lowered by the virus. The next slide. And then I'll skip some of this, but I think the balance of the autonomic system is something that we see often that's impaired. And so I think the next slide, I think we try to find mechanisms both pharmacologically, we can go to the next slide as well, and pharmacologically, to really help people to counteract some of the sort of the challenges that we see when patients have an impairment in the autonomic nervous system. And so we use non-pharmacologic approaches like hydration, like salt, electrolytes, compression. And for some people, sometimes using some pharmacologic agents can be helpful. But again, I think they tend to be a little bit more like gravy rather than the actual meal in this particular illness. And I think that's all I'm going to say for now. I think the next few slides we can go over then I think some of the sort of advocacy components, right? I think the challenge in long COVID is that the symptoms can come and go, and that the impairments can be can make it challenging to be socially included, right? And so I think it's a very episodic kind of disability. And so I think teaching patients how to understand the illness, how to understand the health systems, how to make explicit their beliefs about their illness and about the way in which they want to engage the health system can be really important, right? And then sort of figuring out what roles and responsibilities are really non-negotiable, so that if they're going to burn their energy system, they're doing it for things that are really, really important. And we've come up with some frameworks of how patients can really use social supports and peer support to really improve the outcomes in long COVID. And I don't have the time to go over that here, but the next slide. We can go back to the case. And I think with the 3 cases that we presented, what you're seeing here is that the first case, for example, is VW, who's spending a lot of time in once a week in physical therapy, learning what that energy ceiling is. The second patient is really getting prescribed by the physician what the physical activity plan might be, because that patient, like we had said, had improved to the point where the physical symptoms had improved enough. The third patient was so disabled already that really the physical activity plan is really about breathing exercises, because she was really disabled enough that she really wasn't able to do a lot of interaction. And I'm going to skip to the next slide just to give you an example of some of the other challenges. I think some of the cognitive changes can also be challenging. So for example, the first patient was getting speech therapy for the cognitive changes, but also going to neurooptometry because of the visual processing challenges that she was having. And the VW, I think, the patient with autism, is really having cognitive and social impairment, right? And that's a challenge. We don't really have a good system for where to send adults who have these social challenges. And so that's an example where the health system itself is really now being asked to do something that it was never really doing very well to begin with. And so I think, and that's something that we're constantly having to butt up against when we see patients with long COVID. And I think the third case, for example, is seeing a lot of clinicians, and she's already getting more and more disabled as a result of the fatiguing cycle of the illness. And so I think part of the question is, when we don't have medical treatments for this illness that's been FDA approved, is it possible that she might be doing too many consultations, right? Are the consultations really hurting her because she's crashing directly as a result of some of these consultations? And so if we can just give her some of the tools to pace and maybe get her functioning just a little bit higher than it is, maybe that would be a better time point to be engaging in this much consultation. So I think it's important to acknowledge that often the search for cure can sometimes be counterproductive. And that's an open question that I think at this point in the pandemic, we have to be willing to sort of ask that question for some patients as well. And with that, I think we'll go to the next slide and try to wrap up so that I can take the questions, because I want to make sure that we have the time to do that. And I apologize that it's so little time, but next slide. Right, so we've gone over some of the symptoms, and what I would argue is that energy management and energy conservation is the one thing that we know to work well to prevent the crashes and burns and to really help the body build up the energy system back up. And that comes with physical activity titration based on our ability to assess what their energy ceiling is at the moment that they're being seen by the clinician. But really integrating good psychosocial care, learning about the illness, learning about your attitudes and your beliefs and being explicit about them. And then in specific instances, talking with your clinicians to really try a few things here and there. But when you try things, you have to be able to follow your symptoms, right? The N of 1 treatment trials, because there are no FDA approved treatments for this illness. And so when the clinician is going to try things for you, You have to be able to follow your symptoms daily at home to be able to give feedback as to whether this treatment that we're trying is actually working. And so that does require an amount of self-management that often, if we already had FDA-approved treatments, you wouldn't have had to do. And so I do think that that is part of the advocacy, is to really be able to follow your symptoms carefully enough and to learn how to do that well enough so that you can engage in N-of-1 treatment trials with your clinicians. And with that, I'll stop and take questions. Thank you so much.
This is Lynn. Thank you so much, Dr. Hope. I know there's a lot to cover. There are a lot of questions coming in. There will be a recording sent out. So let's just take the time we need, and we'll move into our Q&A. We have about 25 minutes set aside for this. We know we will not get to everyone. There are a lot of great questions that we received ahead of time and are receiving now. So please be patient and remember that our presenters cannot give personal medical advice. And so we'll do our best to capture a variety of questions right now. So the first question is, sorry. There was a question, Dr. Hope, about the case studies that you shared. Do you know if those people were vaccinated for COVID?
That's a great question. I tried to pick examples, and these were all fictionalized to a little bit, just to kind of protect patients' identities. The first patient, for example, was before the vaccine. The last two, I think, were all vaccinated. And so I do think, although we believe vaccination does diminish the risk, if we look at population data, it does seem to be, if you're vaccinated, your risk of developing long COVID is lower than if you're not vaccinated. I don't think that we can say that you can completely eliminate the risk of getting long COVID if you're vaccinated. So I do think it's likely that if you're genetically predisposed to developing this kind of a post-viral fatigue response, that you may still develop it even if you're vaccinated. And that's something that I think we should just acknowledge as an open question.
This is Christine. I will read the next question that we received in the chat. This comes from a nurse and a COVID patient, kind of a two-parter. She says, I'm curious about the treatment for the dysautonomy or dysautonomic symptoms. Can you answer that? And also, as a patient, what sort of cognitive testing can I do to test my brain? I want to feel ready to return to work.
Those are great questions. So the dysautonomia treatment is actually quite, we're learning a lot more and we're getting better at it, at least at our center. When I first got here, that was something that we weren't necessarily, there's not a lot of good expertise around the world because this is considered a rare illness. And yet almost every patient with long COVID might be prone to getting it. So I think the 4 pillars I think are really key, right? The non-pharmacologic pillars for most people will improve significantly the symptoms. The hydration, the amount of hydration that you need to do is actually can be astounding to some people. I always compare it to kind of like you're running a marathon, right? Even though you can't do as much as you want to do, your immune system is working really, really hard. And so you have to imagine that you're running a marathon every day and really hydrate in a way that like you would if you were running a marathon. And so if you're hydrating for a marathon, typically you hydrate with electrolytes, because if you're going to drink 4 liters of water, it can lead to some other complications if you do that consistently. And so sometimes we just recommend mixing it in with a fair bit of electrolytes. Depending on your individual risk factors, liberalizing salt might be very helpful as well, because I guess because of the electrolyte issues. And then part of what's going on in dysautonomia is that the brain often may be seeing lower blood flow. Even though the blood flow is normal, they're perceiving low blood flow. And so when patients stand up or they stand up too quickly, they get dizziness and lightheadedness. And so we give them tips and tricks around when to hydrate. For example, using compression socks and sometimes even compressing your abdomen. You know, the 19th century sort of like corset might be very helpful, and that might contribute to improving a lot of the symptoms. And then for some people, just because of the nature of their roles and responsibilities, we have to do some pharmacologic intervention even early on, even though we know that the pharmacology is not like sustainably changing the underlying physiology. But sometimes if you literally can't get up and walk to the shower and, you know, and you have to take care of a 2-year-old, like we're going to have to give you some medication to be able to kind of even do some of the basic behavioral interventions to manage the dysautonomia. So I think that's where the art comes in. Getting formal testing of the autonomic system can be done at OHSU and some other centers. And yet, it can be, there's a long waiting list to getting that done, but it can be helpful if you're applying for disability to get that formally done. The cognitive testing, I think, is important, is a challenge, right? A lot of what we're seeing in the cognitive domain is really a subjective difficulty with a lot of the broad processing challenges, whether it be memory, whether it be attention for the brain. And so I think there's a lot of situational factors that will make your cognition worse in a moment, and a lot of emotional factors, those kinds of things. So I would be very careful and ask yourself, why do you need to get a formal cognitive test, right? If you're applying for disability or you're trying to understand how to make accommodations for a job that is very cognitive, then I think it's very helpful, because then you're really going to be testing yourself to inform the kinds of accommodations you need at the job. If you're just testing to quote unquote prove that you have cognitive impairment, that can sometimes lead to some challenging results, because we actually don't know what your cognitive function was before the illness. And often you can test quite quote unquote normal, because a lot of the tests are based on groups of people and the data about normal people. And so if you were super intelligent and you come in and you're getting tested, you might appear quote unquote normal, and yet subjectively you're struggling because it's significantly worse than it was before your infection, and your job requires a high level of function. So I think it's careful to talk about with your clinicians sort of what the reason is for getting tested. And then that's why we work with speech therapists and cognitive behavioral therapists. The skill set of how to improve your cognitive function is sort of like what we've learned is sort of similar to brain injury. And so the skill set for how to improve that is a little bit of a lost art. But if you find the right rehab clinicians, whether it be speech or occupational therapy, we often can teach you how to accommodate the symptoms, how to live with them, and make improvements as well. And so that's kind of what we try to do with our patients.
Thank you, Dr. Hope. This is Lynn. The next question is, for patients that are being seen for long COVID, what percentage are patients that are BIPOC? Is that a factor that can impact?
Such a great question. And I have to acknowledge that, I think it's before I got here. I work at primarily a tertiary care academic center, which I don't know the full history, but I think that we don't necessarily, for a lot of reasons, naturally serve as many of the BIPOC community that we would like at OHSU. And so I suspect that the amount of patients that we are seeing that would fit that description might be lower than are actually affected in Portland, and we're looking for ways to change that. And I do think that because a lot of the symptoms are things like fatigue, things like cognitive impairment, I do think the social context in which people live does impact how they present to the medical system, right? If you live in a multi-generational family for whom you might get access to a lot of social support and lots of help, and maybe you're able to cut back on your work easily because of that social support, you may not present for many, many months. And so because maybe you're able to make the accommodations on your own. And so I do think that that might be a factor. I doubt that there's no real reason to think that the genetics of who gets a post-viral fatigue is any different. And I think we've moved away from thinking of race in that way. And so I suspect that the prevalence of long COVID in BIPOC community is going to be about the same, but how people present, I think, is social. And I do suspect that might lead to some differences. And I think we're working towards having a community that's being treated by us be more reflective of the need, but I don't think we're there yet. And so I'm sort of a little bit hampered in being able to say that I have a good understanding of what the differences might be in dealing with long COVID in that community in Portland, because of some of the gaps in the way OHSU has structured its system before I got here, if that makes sense.
This is Christine. Thanks, Dr. Hope. We're getting a lot of thank yous to you in our direct Q&A line, just so you know. The next question is there a sense of whether or not this condition is, to any extent, permanent?
That's such a great philosophical question. And I'll tell you what I think, and this is a complete opinion. I actually think that it's a chronic illness. And when I say that it's a chronic illness, I actually that does not mean that I don't think that if we can work with one person, we can get you back to a level of function that is very similar to what your functioning was before the virus. But when I say level of function, it might mean that you have to, as a result of having to accommodate, you might have to put a lot more work to get to the same amount of capabilities that you did before, right? The reason why I think it's chronic is because I've seen enough patients who, even before their long COVID diagnosis, they had what I would call a post-viral fatigue syndrome years before, and they've been sort of struggling with how to describe what it is that they've been struggling with, but they've kind of been struggling with a post-viral fatigue for a while. And I myself am a survivor of a post-viral fatigue process from years before COVID. And so I think that a lot of people, because we don't have a name for this, struggle with it and make accommodations in their life and live with it. And then other stressors make it worse. And I do think that by thinking of it as a chronic illness, what it allows you to do is be empowered to recognize what the triggers are, right? And so getting a new viral infection can certainly be a trigger, but sometimes stress can be a trigger, right? Like your mother-in-law visiting for a week in a house that's too small might be a trigger. Like traveling, and not taking appropriate rest might be a trigger. And so if you don't understand what your triggers are and you think, oh, I'm better now, I'm going to be fine, and my symptoms haven't been back for several months, and then you do something that actually is a perfectly normal trigger for a worsening of your symptoms, you might be back where you started, or even worse, and then you're baffled as to quote unquote why this is not better. And so I think thinking of it as a chronic illness and thinking about the accommodations you need to make to kind of not sort of overdo it, if you will, and live within your energy means, I think for me is a lifelong task. And I think if you think of it that way, I think often you can prevent some of the ups and downs of the illness, but that's an open question. And I think a lot of people, if this is their first presentation of a post-viral fatigue, can sort of get to a point where they're living very similar to what they were living before, and they may not think of it as a chronic illness. But I would argue that just the fact that 2 years later they get another viral infection and they're back to where they started, I think it's helpful to kind of have a name for it so that when you see your clinicians in the future, you don't kind of think that it's completely gone. But that's just my kind of sense after having lived through my own post-viral fatigue and having spent 3 years seeing patients with long COVID, is that I actually think it would be more helpful if we called it a chronic illness and give people that ability to really talk about it in those terms over the course of a lifetime. But that's just my sort of instinct.
This is Lynn. Thank you, Dr. Hope. I want to do a time check. We have just under 10 minutes left, so we will address as many as we can. So the next question, I'm going to try to capture a number of questions that have come in that really have to do with medical providers dismissing symptoms of long COVID. So here's one example of that question. We hear troubling stories from a variety of sources that when patients tell their doctors that they have symptoms they believe to be long COVID, the doctors dismiss them and tell them it's allergies or something else. What advice do you have for people who can't get their doctors to take them seriously about this? And what kind of resources does the medical community have to stay informed about long COVID, including symptoms and possible treatment?
Such a great question. And this is such an important part of what the work that I want to be able to do, right? I mean, we've given some fancy terms to this sort of how the medical system acknowledges your ability to know what's going on with your body, right? That sort of testimonial injustice that we often will misattribute it to illness or to allergies or to everything else. You're just a woman who's crazy, right? I mean, and if you read the post-viral fatigue literature from the 19th century, there's a lot of that, right? And then the sort of the other challenge, which I think is something that both the patient and the providers are in, is the fact that because the system doesn't, we finally have an ICD code, which is the things that we can use to bill patients for, but we don't have an FDA approved treatment plan. We don't have, so everything that we're doing is kind of on the edge of the evidence, if you will, right? And that does create a sort of hermeneutic challenge, right, for the clinicians, right? Because if they order physical therapy for long COVID, well, how long is it supposed to be? What does improvement look like? If they order speech therapy, what does improvement look like for your speech therapy plan? And that challenge is something that we're still struggling with. And so I think it's a challenge. And I think what's interesting is that when you look at illnesses for which we have medical treatments for, the reality of it is doctors, and this is maybe a problem for medicine in general, is that we tend to just focus on the medical pharmacologic treatments, right? We give you your insulin and we say go home. And the fact that like you might not know how to exercise with your diabetes, or the fact that you might not know how to tell your loved one that you're diabetic and is something that we don't typically put in the medical space, right? And so I think that some of why doctors might be very inclined to push it away is because they don't really know how to manage, right? Something that isn't really, there's no FDA approved treatment. They don't really have a way of integrating just listening and being a testimonial witness to patients. And that's a deficit that's broad around a lot of what medicine struggles with. So I would argue that for patients, first of all, is to sort of trust your body, listen to your symptoms. And I would say, because the system sucks, right? And because the patient, the doctor, I assume, is doing the best that they can. I'm inclined to think that part of what your job is to be a good advocate for yourself. And that might mean bringing in a family member along with you. That might mean keeping track of your symptoms enough so that when you do get a doctor who's ready to try something, that you're actually able to follow along with that doctor and sort of say, is it working or is it not? And then the other thing I would say is it can be both and, right? Although there's a lot of misattribution, like the notion that, you know, you have dysautonomia, and I'll see a 55-year-old nurse who was never anxious before and is now having heart racing in the ER 3 times in the last 3 months after her COVID. And then for some reason, the ER doctors are going to call it anxiety. And I'm like, yeah, like that's not really the natural history of anxiety to be 55 and the very first time you're presenting with a heart rate of 150. Like that's not the natural history of anxiety. So that's a misattribution. And yet, right, like even if we call it anxiety, then the question becomes, well, what's the management, right? And then it might be that you might have both anxiety as a result of the illness and you might have dysautonomia, right? So you can sort of follow your symptoms enough, trust your gut, be willing to change doctors, be willing to engage with a doctor who maybe is not quite ready to try things, and then be willing to be open to the fact that you might have both and, right? Like you might be also getting depressed from the fact that you've been 6 months of fatigue, and really getting that emotional resilience stronger is going to be a really important component to how you get better. And so sometimes, even though it might not be the reason you're ill, it might be an important thing to be treating along with. And so being open to that as well. And just the fact that you're going to struggle with this is something that you have to prepare for, right? The insurance company might say no 5 times for a particular attempt. And so you're going to have to be patient, not just because you're the one fighting for it, but also the doctor might not have the time to deal with the insurance companies, and that might be an issue. So I do think that the other challenge with our healthcare system, particularly in the West, is that, you know, patients want to present alone by themselves without any social support to deal with an illness that is already challenging enough. And I would argue that that is only making it harder, right? So if you have cognitive impairment, write your notes up beforehand. Be prepared for your doctor with those notes and fax it in or send it in to the MyChart system. Getting people to come with you for the appointment and being completely vulnerable and saying, you know, I'm not going to remember what you say, so I'm going to need you to send me a summary, right? And being very explicit about what the challenges are. Having that person be sitting down and taking notes with you so that like you're not sort of having to do all the multiple things that you do in a visit. And that's really hard because it means that you're going to have to tell somebody that, you know what, I'm struggling and you're going to need some help. But I argue that that's actually a big component of how we counteract some of the injustices that are sort of baked into the system. And yeah, I mean, and I think you've seen in long COVID, patients getting together and really fighting the system, not just in terms of the fact that we even call it long COVID. But I do think that if we just fight the system to quote unquote, give us a name and give us a diagnosis and treat us, what we might end up in is a situation where without any FDA approved treatments, we might just be getting a lot of diagnoses and a lot of treatments and but ultimately you're not actually engaging in a way that allows you to actually get better. Because I do think for some people, there is the potential that the over-treatment can make them worse. I mean, if you're gonna be crashing because you're fighting with your doctor for half an hour, I would rather you not go to that appointment and just maybe energy conserve and sit at home and be than the cycle of crashing. So I think that's a balance that nobody's gonna talk about, but I think we have to look into as well. And so advocacy is this balance of vulnerability, but also kind of being willing to maybe step back from the medical system just enough to sort of learn some of these health principles enough so that you can sort of figure out how to integrate some of those principles into your life as well. And that's tough because I don't think typically the medical system does that for you in any other illness if we had FDA approved treatments. And that might be what you might need from us, is to sort of tell you when to get away from us, because we actually may not be the right people to engage with the part of the illness that you need to struggle with, which is the integrating it into your life. But again, these are ideas that I come to rather than, I'm not saying that because it's what is recommended. I'm saying that really as an opinion, right? So take that with that kind of fat grain of salt.
This is Christine. We've received a few questions from folks who had mild symptoms or didn't have access to testing at the time, but maybe thought that they had COVID. And the question generally is, can a person develop long COVID without ever having been symptomatic or who had mild symptoms for COVID?
Absolutely. Absolutely. I think that, again, the evidence there is not strong in the literature, but I can tell you absolutely. And you know, we are in a pandemic. And so this kind of distrust that patients themselves will have is something that's always striking to me. I'm like, we've all been exposed to COVID in this pandemic. So trust me, if you have symptoms that look like long COVID, it's probably long COVID, Like, I think that we can argue and philosophize about whether long COVID is really any different than any of the other post-viral fatigue syndromes. I am on the side that I think actually it's not that different. And so it could be another virus as well. But I think that for the most part, we're in a pandemic of only one infection right now, and that happens to be COVID. And so if that allows us to call it long COVID and get the kinds of treatments that you deserve to get, I think that that is helpful, because, you know, calling it a post-viral fatigue syndrome is helpful, but it doesn't really allow for the kinds of advocacy lens that I think right now we need. So for me, I think absolutely, we see a lot of patients who, without any COVID infection or without any remembering of any symptoms, can a few weeks later develop a fatigue symptom and with long COVID.
This is Lynn. We're going to push the Q&A just a few more minutes. There are so many great questions, and we are not going to get to them all. But the next question, Dr. Hope, is, do we know if Paxlovid or stress from reducing contraindicated medications for Paxlovid mitigates or exacerbates long COVID?
We don't. I think there's a lot of excitement about Paxlovid, but we don't. And I think that the studies just aren't there yet, that we have to wait for the results. And that's really all I'm going to say.
Okay, thank you, Dr. Hope. I'm going to go to a next question. What about integrating mindfulness meditation to deal with long COVID symptoms?
Yeah, and that's another sort of very easy go-to when medicine, we don't have good FDA-approved treatments. We always jump to mindfulness. And I would argue mindfulness is a combination of multiple things, right? There's the mindfulness in terms of everything that we do, right? Like being aware, and I think mindfulness can be super important when you have to energy conserve and pace. And then there's active meditation. And I think a lot of it depends on the stage of your illness. If you're really severely fatigued and you're, you know, so severely fatigued that you can barely get out of bed, the notion that you're going to meditate on top, like, I feel like that might be a little bit of, again, that kind of like, we don't have anything for you. Why don't you just quote unquote meditate and get better? I think that we have to be careful where we presume that mindfulness is going to kind of cure you. That's not, I think, where it is. But I think mindfulness in terms of being able to be aware of your body, being aware of your posture, being aware of, I think can be a part of how you conserve and how you plan and how you prioritize so that you can live within your energy means. And so I think it's important, but I think we shouldn't over extend or make it seem as though somehow it's going to be a pathway to better, because some people just aren't there yet. They don't have the skill set, or they're not like particularly suited for that kind of intervention. And so we have to be willing to kind of pivot and try other things, whether it's maybe acupuncture or other complementary approaches for some of these treatments. And that's all part of that N of one treatment approach that I think is part of what clinicians do when we're approaching any symptom is, you know, we don't have approved treatment, so let's try some things. But that will mean that the patient has to sort of be following their symptoms enough to see whether the thing that we're trying is actually helping or not. And I think there's a lot of things that can be very helpful if we try them carefully. And so mindfulness, meditation, acupuncture, sometimes light medical massage can all be things that we can try for different types of symptoms. But yeah, that's beyond the scope, I guess, of what I can talk. But that's I can do a whole talk on complementary alternative medicine. But
This is Christine. Is it safe to get the latest booster vaccine? I think we're talking the bivalent booster vaccine. If someone is experiencing severe post-COVID fatigue 4 months after infection and 6 months after their last booster shot.
Yeah, and that's such an important question. And I think, and again, I'm going to say this, and this again is something that people who've been living in post-viral fatigue know this, is that immunologic stimuli can be one of the most important triggers for worsening of your symptoms. And one of the key immunologic triggers actually is vaccines of all sorts, but particularly COVID vaccines. And so for some people, the immunologic trigger makes them a little better. For some people, the immunologic trigger makes them a little worse. And then if you're not at a good plateau, that little worse can be really bad, right? And so I think the way that I make a decision about anything that could be a stressor for your illness is, first of all, is the thing that you're doing worth the benefit, right? Like, so is the prevalence of the infection in your community high enough that you really, is your job? Are you like a nurse? Are you whatever? And I think that's the decision that you and your doctor can make about, like, is this sort of thing that you're trying to prevent, which is COVID infection, because by the way, an infection is an even worse immunologic trigger. If you get a reinfection of COVID, even worse than getting a vaccine, right? So I think that, thinking about the risk benefit for any immunologic trigger, I think is really important. If you're not at a good plateau in your illness right now, if you're still crashing and burning and you're still at 30% function, right? And the risk benefit is quite small, maybe that's not the right time. Maybe waiting until you're at a better plateau when you're at 70% and you have a little bit more reserve. So those are things that you can discuss with your doctor, right? And not just because the official guideline says X, you might have to make a different decision in the privacy of your interaction with your clinicians based on the risk benefit, based on what you want to do, what you value in the world. If you're going to travel to Timbuktu and that's going to be another stressor, that might be a whole different set of calculations of the risk benefit. So I think it's a combination of understanding what the risk benefit of that intervention is, what you value in the world and how you want to live in the world is really important. And then where you are in your illness. Are you at a plateau? Are you plateauing at the point where this is about as good as you're going to get, or can you get better? Are you working on moving in the right direction and maybe you want to hold off for a little bit? And those are all things that you have to decide and be engaged in, and that can be really tough. But that's how I tend to make that decision. I don't think there's one answer for every person. I think it's really like a rubric for making any kind of decision like this. But I would say it is a stressor that you have to be prepared for. And I think for any stressor, that's the rubric that I tend to use to make decisions for patients with long COVID.
This is Lynn. Thank you so much, Dr. Hope. We're going to take a pause now. Thank you, everyone, for your wonderful, thoughtful questions. We know there are so many we couldn't get to, but we will do our best to follow up with as many as we can. Manuel, if you could go to the break slide, we're going to take a small break here. If everyone could please come back at 2:15, that would be wonderful. Thank you. Thank you, everyone. It's 2:15. If you're ready to come back now, that would be wonderful. Manuel, could you go to the next slide, please? Okay, this is Lynn. Welcome back, everyone. Next up, we have Dylan Morgan. Dylan is the Manager for Employer Assistance at the Bureau of Labor and Industries. Dylan, thank you for joining us. Next slide, please. The floor is all yours.
All righty, well, thank you, Lynn. Welcome back, everyone. We are going to take our conversation about navigating long COVID in a slightly different direction at this point and talk about a few of the helps, supports, protections, really, that are available to you at work. And so go ahead and give us the next slide, please. Okay, and as Lynn mentioned, I'm Dylan Morgan. I'm the Manager of Employer Assistance at the Bureau of Labor and Industries, and that means I spend a lot of time talking to employers about what they need to do to make sure that folks get paid, how to protect their employees from being discriminated against or harassed, and also in particular interest here, how to provide protected leave away from work when somebody has a need for that. And so today, go ahead and give us the next slide. I am going to talk about three things. First off, I'm going to talk about your right to provide protected leave. I'm sorry, to receive protected leave. And Manuel, I thought all these animations were just going to come up, so just toggle through and we'll get everything on the screen. So first up, we're going to talk about protected leave under the Oregon Family Leave Act. And that's going to be your right to take time away from work to help deal with a serious health condition like long COVID. Second, I'm just going to introduce reasonable accommodations, which are your rights to changes in your workplace that allow you to continue to do work or to get back to work. And then finally, no spoilers there with our agency logo, but I'll introduce a few people who are just down the sort of virtual hall from me as resources for when option A or option B don't go the way they should. Let's go ahead to the next slide. All right, so out of the gate, I want to talk about protected leave, time that you can take away from work. Big idea here, of course, is that you shouldn't have to choose between your job and getting healthy or helping your immediate family member to get healthy. And most of us, I think, are aware that Oregon laws provide a few helps along these lines. Oregon sick leave law is out there, but as we've discussed, certainly long COVID means an entitlement to up to 40 hours in a given year probably just doesn't cut it. We've also got a paid leave program being stood up here, but it's going to be 9 months or so, or maybe more than that, actually, if I could do my math, before that's really on offer. So in the interim, I'm going to focus in on the Oregon Family Leave Act, or OFLA, as I'll often call it. Go ahead and give us a new slide, Manuel. So OFLA, and punch through about 4 animations here. We'll just get it all on the screen. So the Oregon Family Leave Act requires covered employers with eligible employees who have a qualifying need to receive or to get up to 12 weeks of protected time. So that's time that you can know that your job is going to be waiting for you when you come back. So those 12 weeks are also 12 weeks that you can take as a block, or you could spread it out a bit and take it intermittently. As Dr. Hope has mentioned, there's a sort of an elemental or an episodic sort of presentation with long COVID. That may be what you need to do or how you need to take your OFLA leave. And you can also spread out your leave entitlement by making things, reducing your schedule on an ongoing basis or a predictable basis as opposed to episodically. So those are 12 weeks that can be a pretty helpful sort of, it can be pretty helpful to know that time is there for you. Unfortunately, OFLA isn't for everyone. Let me unpack a few terms here. Go ahead and click the next slide and page up all the animations there. A covered employer, when we're talking about who's covered here, 25 Oregon employees. So companies that have less than that are not covered by the law. They certainly can comply with the spirit of it, but they're not obligated. And in order to be eligible, you need to be an employee with 6 months on the books, 180 days. There can be gaps, of less than 180 days where you're off the payroll, and that doesn't count against you. But you need to be able to put together 180 days on the payroll, about half-time, so 25 hours a week. And then you need a qualifying. I got my mouse in the wrong spot here, apologies. You have a qualifying need. And there are several under this law, but I'm going to focus on a serious health condition. Go ahead and give us the next slide. The serious health condition, some of that is pretty obvious, right? You know, if you go to the hospital for a condition, inpatient care, that's serious. Also, if a healthcare provider says we've got an imminent danger of death or risk of death with a particular condition, that's going to qualify as a serious health condition. But as Dr. Hope was kind of unpacking for us, there's lots of different presentations of long COVID, and those can fit under serious health condition as well. Starting from the bottom here, I'll just skipping ahead. Chronic serious health conditions like asthma or diabetes, those are conditions that are episodic. They can have flare-ups, and they may not be a solid block of time. And there may be other ways to get to a serious health condition. So just camp here for a moment in order to say that whatever your preconception about a serious health condition is, it may be bigger and it may fit into what you need to have for Oregon Family Leave Act entitlement. So give us another slide here, Manuel. Okay, asking for OFLA. So how do we get there? There's no magic words that are necessary here. You just need to say, I need to take some time off for a health condition. And the nice thing about this statute, this entitlement under Oregon law, is that it puts some sideboards around the process. You're going to have to move it forward. The employer has 5 business days to make sure that they've asked for any documentation that they want in order to verify the need for the leave. They don't have to. Some employers just take your word for it and roll, but they've only got 5 days to make sure that they ask for it, and then the process keeps moving forward. Once you've got your medical verification, they may send you to the doctor to verify that you've got a condition, a serious health condition. Employers don't need to know the details of the diagnosis, but they do need to know that it's a serious health condition, and they need to know sort of what the prognosis is in terms of how much time you're going to need, how long it's going to last. And those are things that you can have conversations with your physician about. And physicians are free to write in, you know, this may be ongoing for some time, an indeterminate length of time. And so that can be part of that documentation. And as soon as you get it back to your employer, they've only got 5 business days. So you know that the process is going to move forward for you to be able to get written notice from your employer to say, thumbs up, thumbs down, you can take your leave. And of course, it's a process that can go quite quickly as well, but you've got the assurance there that it's going to move forward, and you can roll that direction. Manuel, let's see what the next slide here is, because I want to pivot from that. We've got a real short amount of time to play with, and talk not just about the time away from work that you may have a right to, but also to reasonable accommodations. And I'm just introducing these, but under Oregon law, individuals with disabilities have the right to reasonable accommodations, and these can be situational specific kinds of things like teleworking or changing your schedule or shuffling around non-essential duties, or maybe even like with protected leave, an additional period of leave to allow for self-care around maybe an episodic flare-up. Go ahead and give us another slide, please. Oregon disability law, yes, thank you. Is covered employer has a qualified individual, which would include an employee who has a disability, and that entitles them to those reasonable accommodations. Next slide. So unlike OFLA, a covered employer here is only requires that you have 6 employees or more, and that's actually more generous than the Americans with Disabilities Act, the federal sort of complement to this. A qualified individual, somebody like yourself who has the skill and experience, education to do the job, but may or may not need a reasonable accommodation, some sorts of changes to allow them to perform the core functions of the job. And then a disability. So we're defining terms here just a little bit. Physical or mental impairment under the law that substantially limits one or more major life activities. And I want to just camp here, as I did with serious health condition, to kind of say whatever your preconception of a disability is, it might be a lot more than that. Major life activities like thinking and breathing and concentration, cognition, these are all things that would qualify. And there's a growing body of documentation and recognition, at the federal level that long COVID is a disability under Title II of ADA, and I'll pass forward on that. But let's go ahead and look at the next slide. When we put all those 3 together, a reasonable accommodation is that thing that in your particular circumstance and your particular job and at this particular time would help you to perform the core functions of the job. You can ask for the moon. The employer doesn't have to give you that. There are undue hardships that would kind of put some limits around what an employer needs to be able to do for you. But as long as it doesn't create a significant difficulty or expense, you've got a right to something that'll help you to get that job done. It may not be your preferred accommodation, but if we can find some way of getting there, that's the point. Go ahead and give us the next slide, please. Bottom line, a qualified individual with a disability is entitled to reasonable accommodation as long as it doesn't create that significant difficulty or expense. Next slide. And so how do we get there? This is what I think is the best part or the heart of Oregon's disability law. It requires a meaningful interactive process. If you're going to comply with this law, there has to be a meaningful interactive process. And so that's a mandatory step in identifying what's going to be workable in this particular situation. It's a back and forth kind of process. It's one that allows for honest, good faith engagement. Let's go ahead and take a look at the next slide. So roadmapped here, just sort of the process for requesting Oregon disability accommodations. Again, there's not going to be a magic word required. I just need a little help to be able to do my job because of a condition I'm dealing with. That should be enough to kick off this interactive process from a covered employer. And they, of course, may need to verify that there is a condition here that meets the threshold of a disability. That's an employer's right. But when we've gotten there, it's that good faith engagement around what's workable that lies at the heart of Oregon disability law. And I've got sort of repeat as necessary because it's an organic process. It could be one and done. A person with a back issue, for example, may need a sit-stand desk and they're good. And that's all you ever have to worry about. But the reality is with a condition like long COVID, the accommodations you needed 2 months ago compared to what you need now, compared to what you may need in 2 more months, are going to be perhaps different as things evolve, presumably, hopefully get better. You can revisit these accommodations and make changes as needed. So just a high-level whirlwind tour of disability law there. Go ahead and click next slide, please. Finally, point 3 here, as I move through my less than 10 minutes of fame. The Oregon Bureau of Labor and Industries, go ahead and click into the next slide, please, has a civil rights division. And that civil rights division, I've got some contact information here for them. Really, I just want to let you know that there is a whole division within our agency, and their big purpose is just to protect workers, protect employees who are potentially facing discrimination or not receiving time that they need in order to take care of themselves or to take care of their families, or in the sense that, or in the event that they're looking at ways to continue to work and they're not getting supports, those reasonable accommodations because of their disability, which we're talking about long haul COVID here, of course. There's folks out there, and it's their career mission to help you. So I just want to give that information out. It's on the slides. It's in the slides that have gone out as well in PDF form, I think before and perhaps even after. But we've got a complaint form that is as easy as filling out a form online. That starts that process, or you can give us a call. You can email us. And I just wanted to let you know that these folks are there. And with that, I will stand ready to take some questions after I pass the virtual baton back to Lynn and Emily. Thanks.
This is Lynn. Thank you so much, Dylan. Next up, we have Emily Cooper. Emily is the legal director at Disability Rights Oregon. Emily, thank you for being here to share your expertise around disability, identity, and accommodations. I'm going to pause before passing it to you and remind people you can raise your hand during the Q&A, or you can message myself or Christine Getman with any questions for Emily or Dylan. Emily, the floor is yours.
Thanks, Lynn. My pronouns are she and her. I'm a middle-aged white lady with my mid-length brown hair pulled back into a bun. I'm wearing blue glasses, and I just moved, and so I live in an empty house practically, so you may be hearing echoes or blank walls behind me. Next slide, please. So part of what I want to talk about here is what Dr. Hope mentioned a little bit, is where you move from, needing medical care to looking at really the social model of disability. And navigating identity is difficult in all times, but especially navigating disability identity. As a person with a disability, there's so much bias I deal with and presumptions about my abilities simply based on my diagnosis that it's not surprising that A, it took me a long time to be out about my hidden disability, and B, why people experiencing long COVID, along with all of the physical symptoms and mental symptoms, may also be dealing with, hey, I'm now protected under the Americans with Disabilities Act and Oregon disability law. What does that mean? And I'll be candid with you. I think part of my journey in coming out as a person with a disability is, one, I know that bias is wrong. I know that my mental health condition actually makes me a better lawyer. I know how to handle stress. I made the joke once that trial's not scary when you're worried about the sky falling any minute. I have a good balance of being able to deal with fear and anxiety. But I also know that it's important to come out of the closet. So as a queer person, I also know that there's an array of queerness, just like there's an array of disability, and there's no level of like disability appropriation if you notice that you have a hard time doing things like thinking, breathing, standing. Those are all protected under state and federal law. Next slide, please. So the Americans with Disabilities Act, it's been alluded to, talk about you qualify as a person with a disability if you have one or more major life activities impacted. And I have included on here all of those examples that are in federal law, but as Dr. Hope talked about, a lot of the conditions related to long COVID impact major life activities like breathing, walking, talking, sleeping, and working. And that includes respiratory, circulatory, or reproductive functions or endocrine functions. And so these are all potential qualifiers for disability. And I'm going to put in the chat, the federal government, the Health and Human Services Office of Civil Rights has issued guidance regarding when long COVID meets the definition of disability, because just like any other legal definition, how someone perceives you and how you perceive yourself is different than a legal definition of, do you have a condition that impacts an activity of daily living? So you could have long COVID, but still be able to breathe, work, walk, etc. And you could also have long COVID and not be able to do those things. So that's the main question in determining whether or not your long COVID meets the federal definition of having a disability. Next slide. And so, to dive into it, what I've heard Dr. Hope say is that there can be existing lung damage caused by long COVID that impacts not only the shortness of breath, but the fatigue he repeatedly mentioned. And that fatigue has an impact also on memory and brain fog. That's one of the biggest symptoms I've heard about long COVID. And then also sort of any gastrointestinal issues could also impact. And I'll give you a really good example of this. When I first started doing disability advocacy, it was at the beginning of the, right before the cocktail for folks who had HIV and AIDS. And it was really hard to get people on disability then, similar to long COVID now. And one of the stories I had to explain was there's wasting disease that impacted a lot of gastrointestinal dysfunction. And so we had to, as advocates, explain, sometimes in painful detail, how someone's HIV or AIDS status impact their ability to work based on the location of and the need to use a restroom. And so it's a very humbling, and I go back to bias. I think identity is hard. Asking for these accommodations are hard. But what isn't hard is becoming part of this disability community. We're here to support you. We're here to answer your questions. We also recognize that long COVID is going to be episodic. So there's a lot of me that identifies with folks who have long COVID. Some days I'm doing really great. Some days I'm not doing great. But when you're qualifying for services or you're asking for help from an employer, sometimes it's that balance of maybe describing what you're like on a bad day. Next slide, please. And so if you're seeking employment accommodations, there is a couple of ways to do it. This is kind of my cheat sheet. First, is there a workplace barrier related to your disability? As Dr. Hope talked about, is it a hard time for you to stand up for a long time? And if so, then can you ask for an adjustment? You know, for example, if you're working at a coffee chain and you're at the register, asking your employer to say, have a stool or a place where you could sit. And so that's where there's no magic words. That's just can begin the interactive process. And then again, to the right on this slide, there are a few resources. The Health and Human Services Office of Civil Rights web link. There's also the United States Equal Employment Opportunity Commission, or EEOC. In addition to BOLI, they can help navigate any sort of federal employment concerns. And then I really love JAN, the Job Accommodation Network. They're really great. If this is your first time asking for accommodations, kind of walking you through the pitfalls, as well as my organization. So that's all I had. So I'll wrap up so we can get to questions.
This is Lynn. Thank you so much, Dylan and Emily. So we have about just over 20 minutes set aside for Q&A. And again, we probably won't get to all of them, but we'll do our best, and we'll do as much follow-up as we can. So Christine and I are going to tag team questions between BOLI and DRO, and I will kick it off with the first one. Dylan, this is for you. Reading more about OFLA online, Oregon Family Leave Act online, is it true that you cannot apply for benefits until September 2023?
So we've got a couple of things crossed over one another. This is Dylan, of course. The Oregon Family Leave Act is a law that's been in place for quite some time. The Paid Leave Oregon program, they changed their name, so it throws me off a little bit. But the Paid Leave Oregon program is going to offer a similar sort of entitlement of up to 12 weeks, and in some cases more, for a set of serious health conditions and other things. But and it comes with a sweetener, of course. You've got some sort of wage replacement insurance that's going to come with that. So it's paid leave as opposed to OFLA, which is time off and it's protected, but not necessarily paid unless you've got other leave banks that you can draw on while you're taking that time. So with the Paid Leave Oregon program, that isn't, contributions are going to start here in January. So we're building up a trust fund of insurance, essentially, against which claims are going to be allowed starting in September of 2023. So OFLA is available now. Paid Leave Oregon coming soon. Well, you know, soon if you mean months down the road. So soon in government speak.
This is Christine. I will read the next question. And I think, Emily, I will direct it to you. The question is, what judicial, legislative, or administrative action definitively established long COVID as a condition entitled to protection under the Americans with Disabilities Act? What is the salient attribute that supports that result? When, oops, my window just moved. When, to my knowledge, Parkinson's disease, which has been around for longer and has been diagnosed in at least 500,000 Americans, has not been determined to qualify as a disability entitled to ADA protections. Can you touch on those differentiations?
Yes, and so as I mentioned earlier, the United States Health and Human Services is the agency that enforces federal laws regarding, in this case, the Americans with Disabilities Act. So the federal agency in charge of enforcing the federal law around disability has issued guidance, and that's what's in the chat, regarding long COVID meeting the federal definition of disability. And outside of that guidance, if you look at the precedent of court cases across all the circuits around what disabilities qualify for federal protection, it's less about the name of the disability and more about whether it impacts your activities of daily living. A good example of that is Michael J. Fox has been diagnosed with a condition that, you know, at times impacts his ability to work and at times does not. And so the question for purposes of whether or not your condition meets the definition, the federal definition of disability, is if it impacts one or more activities of daily living.
This is Lynn. Thank you. The next question is for Dylan. If an employer isn't negotiating an accommodation fairly and you make a bully complaint, how long does it typically take to hear back? Is there a large backlog now because of the pandemic and more people becoming disabled?
I'm going to have to plead a little bit agnostic in the sense that I don't work with that division. What I will say, and just shoot it straight, is it's not an instantaneous fix. To file a complaint with BOLI kicks off a legal process in which everyone has rights, and there's quite a bit of steps involved. So it can take time. It's not going to be like in a week an investigator is brought the hammer down on your employer. However, we are making we are getting a lot better at clearing out backlogs, and so cases are moving forward quite a bit better. What I can't speak to is whether or not that log has gone up or down as a result of disability claims, that are in connection with long COVID. So I can't speak to that. We could probably find that answer. I just don't have it handy with me.
Thank you. This is Christine again. We have a few questions that are written in first person, but we've combined them because they are applicable to many folks joining us on the call today. So this next one says, I had private disability insurance through work and I left work due to long COVID. The insurer denied my disability claim and their reasoning showed a lack of understanding of long COVID. I am seeking legal help to appeal. I suspect this problem is very common. Is any organization doing broad advocacy or even a class action lawsuit?
This is Emily. I'll try to answer that question. I'm not aware of any organizations bringing a class action lawsuit. For that question around the private insurance, I think what you have to look at is the contract, the summary plan description is what they're called, between your employer and the insurer. And that's the contract that will not only explain short or long-term disability, but also appeal decisions around that. And so the litigation would look more like a contract enforcement than, say, a discrimination case. But I think as more information and frankly more physicians and the medicine is keeping up with this pandemic to help explain, that long COVID is a condition, it is diagnosable. What's tricky right now is getting that objective medical evidence and then figuring out what's your legal hook. And for that question, again, it's going to be your summary plan description or your contract with your previous employer. So something you or your attorney may want to think about is asking for that contract, because then you'll be able to see the actual terms of what they should have done. And that may be the legal hook to push back.
Thank you. This is Lynn. The next question is for Dylan. This person writes, they're thinking that there are workplace protections for documented workers and wondering if there are any protections in place for undocumented populations.
Okay, I'm going to make an assumption that we're talking about documentation, work authorization, I-9 eligible, and if I'm in off base, rephrase the question, let me know. So the protections around, say, wage and hour and civil rights laws really don't have a whole lot of a connection to whether or not you work authorized. If you performed the work, you became the employee, whether you should have or not under some immigration law, it becomes sort of irrelevant. And so the protections for employees remain and persist. So there's, if that gets to the question that was asked, and I'll just pause here and make sure that that's the case.
This is Lynn. I'll pause and I'll message the person and try to find out. And so we can move to the next question in the meantime.
Great, thanks.
This is Christine. We have a combination of questions about getting support monetarily and with ADLs. So can you discuss how those of us with disability who live alone and have little or no family can get help when necessary?
It's a really good question, and unfortunately, it's not an easy answer or easy solution. What we have here in Oregon is combined programs that have different eligibility requirements. One is what's called APD, or Aging and Persons with Disabilities. That's a county-based program that looks at eligibility both in terms of medical need and categorical needs, so what your medical needs are as well as your income. There's also waiver services that's through our state's Medicaid system. And then there are also what's called PSWs, or personal service workers, where you can become eligible for in-home supports under what's called the Choices program. And if you get eligible for that, then you either hire or the state hires folks to come into your home. I think what's difficult is even once you get each hurdle and become eligible and provide all the documentation, both medical and income in some cases, there's a real lack of providers right now. So there are people who are eligible for hours. I will tell you right now, I have a really good friend who's eligible for 30 hours a week and is only getting 10 hours of paid time. It's really difficult right now. I think I could go on and on, but I think the staffing shortages in community in-home care is awful. In part, I think it's because the licensing and pay is awful. But that's my not so hopeful answer. But I think the thing you should probably do is reach out to wherever county you live, check in with their long-term care or adults and persons with disabilities program. Those would be two good places to get started. And then I'll put in the chat the Disability Resource Connection, which is another good resource.
Thank you, Emily. This is Lynn. The next question is for you, Dylan. Is Family and Medical Leave Act different than OFLA leave?
Okay, so Dylan here. Yes, Family and Medical Leave Act is a federal law, and Oregon Family Leave Act is, of course, our state law. They're very similar programs, but when I kind of walked through or raced through, what a covered employer is, who's an eligible employee, and what serious health conditions are, there's some differences there. And typically, our Oregon law is going to be more protective, more beneficial for Oregon employees. For example, a covered employer under federal law, the FEMLA, or Family and Medical Leave Act, would be 50 or more employees, and eligibility is computed different, and serious health conditions are somewhat more circumscribed. The reasons for taking leave are fewer in most cases, and there was one other thing I wanted to say about it, and it's escaped me. But so they are very similar laws. If you're eligible for both, your entitlement draws down for both. If there's some sort of eligibility gap where you qualify for one, you can take some protected time under one, and then when the other one kicks in, then you can take time as well. Both of them are similar, though, in the sense that they provide protected leave from work, and so both are options. Yeah, I really do feel like there was something I missed, and if there's a pushback or a follow-up, I'm happy to grab that train again and see if I can answer it.
Thank you. This is Christine. The next question is, what can be done when an employer agrees to a shortened workday for returning to work post-COVID, yet does not provide employee support to allow this?
This is Emily. I'll try to answer that. And Dylan, tell me if I've missed anything. I think what's tough about the interactive process is that it's a term of art where basically the employee gets to say, I want this. Employer gets to say, no, but I'll give you this. The employee says, well, what about this? There should be a lot of back and forth. That's good because it allows there to be a robust conversation about what the employee needs and what the employer can provide. The downside is it can be a lot of back and forth, and can feel exhausting. And so what I would urge you to do is A, make sure you're documenting these things. And B, saying, hey, when I talked to you on this date, I said that I needed to have a flexible work schedule and whatever that agreement was. Say coming in at 10, but staying through 6, or whatever the agreement, the flexible beginning of the day. You know, I got in at 10 yesterday and I got flack. I need your support by, you know, and fill in the blanks of what that support looks like. For example, I need your support by letting my supervisors and coworkers know that this, you know, I'm going to have a flexible work schedule based on my accommodation request. Because my hunch, and I don't know, but my hunch is what's difficult about this as an employer, also have to maintain the confidentiality of employees and their private health information, including accommodation requests. And so part of the interactive process should be who needs to know about your modified work schedule and how is that best communicated to both allow your team to know and you get the support you need for that schedule without sharing protected information.
Emily, I think that's a great answer. The only thing that comes to mind for me is we really haven't come to rest on a reasonable accommodation if, you know, at the point that we're asking the question, we have a reduced schedule to do the same amount of work. You know, the support that you need to be able to do the work, you know, to do the schedule that you're taking on as an accommodation to a condition really needs to you know, we're going to have to shift expectations and productivity. The time that you're there and working, you know, productivity, you still need to be able to do the essential functions of the job, but negotiating for clarity around, you know, better boundaries, not just with the time, but with the duties, maybe sort of the next back and forth. And while that can be tiring, and I recognize that's particularly tough here, it's a protected part of the process that you can come back and you're not precluded from taking another bite of the apple here. Just getting the schedule wasn't the last piece. We need to make sure that it's working for you.
This is Lynn. The next question I'm going to direct to Dr. Hope and Emily. So this is a bit of a medical question, but also could be a bit of data that you may be dealing with. Do you have any idea how many people with long COVID are dealing with difficulties with one or more activities of daily living in Oregon?
This is Emily. My response will be easy. I don't have that data. I don't know if Dr. Hope does. I know that Oregon is required to track data like race, ethnicity, age, language, and disability status, but I don't know how that relates to long COVID. So I don't know that answer. I think it's a really good question though.
And my answer is pretty short as well. I don't know that answer either. I think that's something that we'll have to look into at the research side, unfortunately.
This is Christine. Next question is, how do ADA accommodations interact with the OFLA FMLA?
I will certainly take a bite at that apple. So as I tried to kind of set up, you know, OFLA and FMLA, those protections under law, state and federal law. Apologies. Thought I disabled the phone there. Those are protections for time away from work, whereas, you know, ADA is all about the changes that you may need for your work, you know, situation to allow you to continue to work or to get back to work. And so there can be a little overlap in that they both may provide a period of leave to get you where you need to go. But they're two independent requirements for employers from that perspective. And so, you know, an employer needs to give you the time that you're entitled to under OFLA or FMLA, the federal version of OFLA. And an employer also needs to engage you around any accommodations that you request or need to accommodate a disability. So both of those are on the table. One doesn't mean that you don't get the other, although it may be that, you know, the time that you take for OFLA allows you to, you know, to get where you need to in terms of an accommodation as well, and vice versa. So I hope that helps.
This is Lynn. This is the last question, and it's going to go to all three of you. And we just have a few minutes. So here's the question. How can we educate better employers and medical doctors about long COVID? Every time I get fatigued after having COVID, or every time I mention my brain fog to a doctor, I get dismissed. The only people who seem to understand are those who feel the same after COVID.
This is Emily, whoever asked that question, I so relate to you. It reminds me of the first time I tried to get accommodations for my mental health diagnosis and my physician told me to cut down on coffee. Like if I had less caffeine, I would be less nervous when I have a diagnosed anxiety disorder. It's just, I think it's real that, you know, bias exists, A. B, there's a lot, I think, in medicine right now that is still trying to figure out the implications of not only COVID-19, but its long-term impacts on the body. And so in that in between, I think there's a lot of room to dismiss. And I'm just going to be even more real. I think if you're a woman, if you're a person of color, if you're an older adult, we know that those are the traditional, or a person with a disability, those are the traditional marginalized in terms of healthcare disparities. When you look at it across the board, not just COVID-19, but cancer and screening for cancer, kidney disease, et cetera. Like we just know that there are communities that have already been marginalized that already show up with being dismissed and how that impacts healthcare outcomes. So long COVID is just adding to that list. So my personal advice to you is that you try to find a very good clinician to support you. And again, it's not easy, but I think when you find a good clinician that can have that therapeutic relationship with you and can support you, that is the gem to find, and it's difficult. But once you have that, you then have that support to be asked to educate employers, educate the folks around you about what you need. And I think that's the trick, but it's really hard to find that provider. So that's my personal take, and I'll turn it over to Dylan and Dr. Hope.
Yeah, I'll wade in. Another angle to that same sort of question, and speaking less about clinicians, and more about your employers, is just to kind of think about what language they speak, in the sense that they're managing a business, risks and liabilities, and they probably feel much more comfortable with authority for making business decisions. Essentially, accommodating you is going to be shuffling work around or doing something. In all of those decisions kind of fall into the realm of cost benefit from an employer perspective, and so providing the sorts of authorities that are persuasive. And I'm thinking in particular, I think Emily put a link to the HS Health and Human Services sort of discussion about long COVID as a disability that employers are legally required to try and accommodate. That's the sort of piece that if it hasn't come up in the conversation, ultimately, you may need to go there, and finding that gem of a clinician may be similar to finding that, an advocate, or whether it's an agency or a private attorney, somebody who can say, look, ultimately this is going to create risk and expense if we can't get this resolved. And that's also part of, I don't want to say that that's the big piece here, but it is part of the question and part of the response, I think, to put things in terms that folks understand, and to lean on wherever we can, authorities, that have been laid out for us. Talking again, I think Ian has just top posted that link, so I appreciate that.
And I'll weigh in just to say quickly that, first of all, I think that this is the nature of living with a chronic illness, is that you're always having to educate not just your clinicians, but your family and your loved ones and the people that you care for. And I think that might be the kind of thing that if you can find the time to find a clinician who can be a good advocate with you, that privilege of getting that clinician can allow you that resilience to be able to do that work, which is constant, right? But I like the sort of disability process in that it is this interactive, right? The clinician might be willing over time to get, and might be willing to get better, but you have to engage them in that learning. And so speaking their language and asking questions and being explicit about what your beliefs are and what you're struggling with, I think is really helpful. And then I would also just say that sometimes people are trying to keep their lives exactly the same, right? They want to keep the exact same job. They want to keep the exact same, house. They want to, and sometimes that's not really what the disease and the stage of illness that you're in, that might not be the right choice. And so often, if you're really hitting yourself against a brick wall often, and nobody's there to support you, it may mean that your approach to problem solving might require some really hard choices. It might mean you might need a different job. It might mean you might need a different level of social support. And that's really tough to do on your own. And so that's why I think sometimes having other people, even if it's not a clinician, being there with you to really help you make those tough choices, because nobody's going to tell you to do that. And yet that might be sometimes what's called for. But it's tough. And I think give the whole system some grace. But being sort of forceful as well, I think doing both can be really hard, but that's kind of what often you're called to do with these chronic illnesses, but long COVID is one of them.
This is Lynn. We are right just a minute over time, so I'm going to close us out. I want to extend my sincere gratitude to all of our speakers and also to all of you for showing up here, for your time, your energy, your thoughtful questions and care. We hope that you come away from today with more knowledge and resources, but we know that the impacts of long COVID are long lasting and there's still so much for us to learn from each other. Please reach out with any follow-up questions, feedback, or concerns. Our email is community.phd@odhsoha.oregon.gov. And I think if you could drop that in the chat, I see it in the chat. You can expect a follow-up email with this webinar recording, the slides, and an FAQ document in the coming weeks. In the meantime, take good care of yourselves and thank you for being here.
Thank you.